Welcome to Chapter 13, Trauma and Stress-Related Disorders. These are the key terms recommended by your text that you should know in order to understand this content. These are the chapter learning objectives that we will be covering in today's lecture. So the book starts off with the introduction that many people experience events in their lives that are extraordinary, intense, and have severity to them that pushes us well beyond what stress of a daily life would be. And these traumatic events or stressors would be expected to disrupt the life of anyone who experienced them, not just individuals at risk for mental health problems or issues. These traumatic events or stressors could be individual traumas and stressors, such as maybe child abuse, type 1 diabetes, heart conditions, um, or we can have large-scale traumatic events. And large-scale traumatic events would be things like war, terrorist attacks, natural disasters. The global pandemic has impacted significant changes, especially for healthcare workers, first responders, and those who were severely affected by COVID-19. It created a lot of social isolations, economic losses, and disruption of people's daily lives, and is now considered in this category of trauma stress. So some characteristics of stress and trauma. Most people experience anxiety, insomnia, difficulty coping, grief, and other responses during traumatic events, but eventually they turn to normal functioning. Some individuals struggle to cope and manage stress or resume daily activities after the event. These individuals might develop an acute distress disorder, adjustment disorder, PTSD, or dissociative disorders. So the DSM-5 classification, PTSD is distressing behavior and pattern resulting from experiencing, witnessing, or confronting the traumatic event. So first and foremost, we have to have some type of event, episode, something happened. And then that in itself had to create an actual or a threat of serious harm, injury, or death. The response is usually that intense fear, helplessness, and then clients are going to have symptoms associated with that we'll talk about in the next slides to come. The assessment, we can do a life events checklist, which is an LEC5. It's used to screen individuals for a history of trauma. It's a self-reported tool that we can use. So the symptoms, we have 4 categories of symptoms that these clients are going to report. They're going to have re-experiencing. So re-experiencing would be reoccurring memories, dreams, flashbacks. And then they have avoidance. And avoidance would be steering clear of trauma-related stimuli. So they might not want to go to places they've been. They might not want to associate with people that they associate with that trauma, or they don't want to go back into those situations. We have negative cognition, which is a feeling of detachment, numbness, and loss of control. And then we also have hyperarousal. So that could be insomnia, hypervigilance, somebody who is always on the lookout, irritability, and angry outbursts. So usually, if you're going off the DSM-5 criteria, they need to have so many of each of these for us to give them that true diagnosis. The impact, it typically leads to isolation, which worsens their negative emotions. Symptoms do fluctuate and intensify during periods of stress, and it can co-occur with other disorders like substance use, anxiety, and depression. Diagnosis and course, symptoms appear 3 months or more after the trauma. So if they have a traumatic event, and it's like a day to a month, we usually consider that to be an acute stress disorder. Once it goes beyond that period, then we can kind of look at it as being PTSD. An adjustment disorder fits within that too. We'll talk about that more later. Um, Delay can be chronic in onset, and we want to, again, use that PTSD checklist um, and the life events checklist. About 60% of individuals develop PTSD, but 50% of those recover in about a year. So, our related disorders. We have adjustment disorder. So, adjustment disorder is 1 month and it's usually resolved in 6 months. This is a reaction to a stressful event that causes a significant difficulty in coping. Common triggers could be issues with financial changes, relationships, and work related stresses. Treatment for this is usually outpatient counseling or therapy. With an adjustment disorder, think somebody that lost their job, maybe they keep going back to the job and they're just not able to reassimilate a life without the loss of that job. Acute stress disorder. So this occurs after a trauma and it's like 3 days to 4 weeks after it. This client is going to experience that re-experiencing, the avoidance, and the hyperarousal. It can be a precursor to PTSD. So if the acute stress disorder is not resolved in 4 weeks, then we're starting to look at it as PTSD. We have treatments of cognitive behavioral therapy, and that helps prevent them from having PTSD. Again, this is before PSD occurs. Once we go beyond that point of that 4 week period, then we're transitioning into that. Reactive attachment disorder and disinhibition social engagement disorders, both are for children. So, reactive attachment disorder develops before age 5. It's typically due to abuse or neglect. This child is going to have minimal social emotion responses. They're going to have lack of positive affect. They're going to appear sad, irritable, and fearful without cause. Disinhibition social engagement disorder also develops before 5 due to neglect. These kids are going to be over comfortable with strangers. They're going to lack the usual hesitation when approaching somebody they don't know. With both of these disorders, if we have deficient parenting or institutionalization or a lot of foster care, those kiddos can get this. So, more etiology about PTSD. Classification. Previously, it was classified in the anxiety disorder, and now it's in its own subcategory. It requires, again, that causative traumatic event. Unlike anxiety disorders, which no event needs to come for us to have those symptoms. Risk factors for PTSD, primary predictors would be a direct involvement in a physical injury that leads to some type of loss. So it could be a single event, or we also have additional risk factors such as pre-trauma, which is a lack of social support, um, prior psychiatric history, and personality factors. So if somebody has those things and then they have a smaller traumatic event, it could lead to it. And then we also have post-trauma, which would be a lack of immediate counseling after the incident occurred. Combat-related risk factors. There's some personal factors that are lower education, non-officer rank, those that are in a combat role, those that have already been previously trauma or have prior psychological issues are at a higher risk for this. Deployment factors, the number and length of deployments somebody goes through, and then trauma exposure, like were they firing a weapon? Were they witnessing or causing casualties? If they were a prisoner of war or a civilian in war, we also expect there to be some possible PTSD. PTSD considerations across the adolescent. So, adolescents and PTSD they're more likely to develop PTSD, adolescents more so than children and adults. Risk factors are their age, their gender, the type of trauma, and if they experience repeated trauma. It places them at an increased risk for suicide, substance use, social and academic difficulties, and overall poor health. Treatment for our adolescents, we're going to use trauma focus CBT, which is that cognitive behavioral therapies. This has been long-term, this has a lot of long-term benefits to it. And the PTSD can interrupt biological maturation on these kids. So they might get kind of stunted at that area or point in their life. Children and PTSD have a higher risk with developing depressions. They are more at risk if their parent has depression or they suffered child abuse. Paternal psychopathy creates stress-laden environment, which increases the risk of PTSD. Children really should have post-event counseling if they're in an event. And participation by their parent in the therapy group helps improve both the child and parent outcomes. Considerations for the older adults, children or adults, right? We're talking about older adults, not children. Okay, so hip fracture can actually trigger PTSD. Our clients who've been in war and have combat fatigue or shell shock, especially those people that are now in their 60s, might have been in the different wars, which puts them at a higher risk for this. PTSD reduces quality of life overall. It impacts physical health. It can be linked to premature aging and dementia, and it's really essential for our older adults to receive treatments. Cultural considerations. So global prevalence of PTSD. We know that PTSD is a universal phenomenon. It occurs worldwide. Limited research on cultural aspects of PTSD treatment and recovery. We just don't have it. It isn't conducted the same way as other disorders get a lot of research. We do note that there's an impact of displacement. War and political oppressions contribute to mental defect, alienation, lower resilience, and poor long-term outcomes. And all of those are linked highly to the development of PTSD. When we talk about cultural identity and resilience, strong cultural identity is associated with lower PTSD rates and better recovery outcomes. This suggests that cultural allegiances enhances resilience against PTSD. And then we also have culturally tailored PTSD treatment. So therapists should consider patients' cultural expectations and help seeking behaviors. CBT and other treatments should be strengths-based, client-driven, and incorporate culturally relevant beliefs about their illness and symptoms. So what are our treatment options? General treatment approach, we can do counseling for acute stresses. And if we do counseling during that acute stress disorder, it can prevent PTSD. We can do outpatient therapy, which is the primary treatment for PTSD. We can do medications that are symptom specific. So if your client's having insomnia, we can do something about that. Combination therapy of both CBT and medication produces the best results. Inpatient treatment is typically not required, but it may be if your client is in a severe crisis. So if they're having suicidal thoughts, overwhelming flashbacks, they might need an inpatient stay. Our therapeutic approach, we can do cognitive behavioral therapy. Again, most common and effective formal treatment. We can do exposure therapy, which helps the client confront avoided thoughts, emotions, and situation using real world or imagine confrontation to reduce fear responses. We can do prolonged exposure therapy, and they find that that's effective for military personnel and veterans. When we talk about adaptive disclosure, this is short term. It is military developed CBT approach. It uses exposure therapy, empty chair techniques, expressing thoughts to an imagined person. It's noted to be effective in reducing PTSD symptoms and fostering post trauma growth. We have our cognitive processing that can help rape survivors, combat veterans with PTSD. It focuses on reframing negative beliefs and involves reading aloud personal trauma account with a more balanced worldview. There's also a eye movement desensitization that your book doesn't talk about, but it's becoming more popular. And that's when the client works one-on-one with a therapist, does these eye movements while they go through it. It has a whole bunch of phases to it. It's very specialized, but it's to help retrain the thought process of the brain. It's pretty cool. And then we have medications that we can use with these guys. So we can do SSRIs and SNRIs are the most effective. So our fluoxetine, paroxetine, sertraline, venlafaxine. Benzodiazepines lack evidence as use, but you will see them very often in practice. And then again, the combination of CBT plus medications is more helpful than just medications alone. So next we're going to talk about dissociative disorders. So dissociations are the body's defense mechanisms. It's a subconscious coping strategy to protect against the emotional impact of trauma. It helps the mind detach or forget painful memories. It can occur during or after a traumatic event, and it actually becomes easier with repeated use. Dissociative disorder overview involves disruption in conscious, memory, identity, or perception. It can impair relationships, daily functioning, and your ability to cope during trauma. It varies in intensity onset. It can be very sudden, it could be gradual, and the duration could be transient or chronic. Prevalence, it is rare in general population. We find it more common in children that have experienced physical and sexual abuse. Increase in diagnosis recently may be due to greater awareness of mental health issues by our mental health professionals. Dissociative identity disorder, DID, truly remains a controversial diagnosis among psychiatrists as a whole. So we have a few types of DID. We have dissociative amnesia, which is the inability to remember important personal information, usually related to trauma or stress. It could include a fugue state where the person moves to a new location, forgets their past, and may assume a new identity. Then we have DID, which is the dissociative identity disorder, formerly called multiple personality disorder. This is when we have a presence of two or more distinct identities or personality traits that alter control over behavior. And what we're going to see with that is memory gaps regarding personal information depending on which personality is at. And then we have depersonalization, derealization disorder. So, a depersonalization, the client may report feeling detached from their own thoughts, emotions, or body. With derealization, they have a feeling as though the environment is foggy, dreamlike, or unreal. The client remains aware of realities and is not psychotic with this. Our treatment options, therapy for the dissociative disorders. We need to focus on reassociation, helping the individual integrate their different consciousness. It aims to improve quality of life, functional ability, and reduce symptoms. Long term therapy, either individual or group based, is common. Medications can be given for anxiety and depression if these clients have those symptoms. Short-term hospitalization treatment with trauma survivors. Clients with PTSD or dissociative disorders are often seen in various healthcare settings. Acute care hospitalization is rare and usually occurs when we have a safety concern or a severe symptom escalation. Hospital treatment is usually short term and focuses just on stabilization before returning them to community based care. Common symptoms in the acute care setting are going to be flashbacks. Clients may appear terrified, they may cry, they may scream, they may attempt to hide or flee. They might have dissociations where they're speaking in a different tone, appearing numb or vacant, or showing emotional detachment. Clients may express intense rage, anger, or emotional numbness, and they may struggle to identify their own feelings. So our trauma-related assessment, what are we going to see? General appearance of these patients, they're going to be hyper alert. They may have discomfort with physical closeness. They may appear anxious or agitated. Their mood and affect, they may range. They might have passive anger. They might be frightened. They might be agitated. They might be hostile. Their thought process and content. We might have nightmares, flashbacks, intrusive thoughts, hallucinations, self destructive thoughts, sometimes fantasies. When we talk about sensorium and intellectual processes, we might have oriented to reality, but not when they're having flashbacks. They might have memory gaps, or they could have thoughts of suicide and self harm. For insight and judgment, they may report little idea about relationship between the trauma and the symptoms. Some of them might be really knowledgeable about what's going on, and some of them just might have an impaired ability to make any decisions themselves. Self-concept, we can see low self-esteems, low self-worths. With roles in relationships, often we have problems with authority, and close relationships are going to be difficult and sometimes even impossible. Psychological concerns, they might have difficulty sleeping, changes in appetite, and substance use with alcohol and drugs. So when we talk about our data analysis and our priorities. So, if we were doing our ADPI, we would have our assessment. Now we're doing data analysis to get to our concepts and diagnoses. First and foremost, it's always the safety, right? So we want to make sure that the client is not at risk to hurt themselves or harm themselves. We want to help them with coping. They might have ineffective coping. They may feel overwhelmed by their stresses and emotions. Chronically, they might have low self-esteem, feelings of helplessness and hopelessness. They could have some disturbed sleep, some sexual dysfunction, social isolation, and again, risk for suicide highest. So our outcomes will be dependent on our problems, right? If we want to make sure that the client's safe, your outcome would be that the client is safe, and so on and so forth. So what are your nursing actions? Nursing actions, right? Client safety, top priority. We want to make sure that we're doing that good assessment on self-harm and suicidal risk is always crucial. We want to manage any self-harm thoughts that they have. We want to make sure that they're in a safe space. Um, Close to the nurse's station. Maybe they need a one-on-one sitter. Comfort items, if we can allow them to have, blankets, photos, things like that. When we're talking about coping and stress, we can give them grounding techniques, which I'll talk about more on a few slides. We can support their self-esteem, view it positive that they're a survivor. Sometimes these clients will have guilt of being a survivor, but we need to help shift that and empower them that they're strong and they're a survivor and that that's okay. We want to establish social supports. So help them create a list of people that they trust, activities that they enjoy. Make sure that they have crisis hotline numbers. Get them in support groups, help them with one-on-one in person. therapies, social engagements. And we really want to reduce the isolation that they feel. It's also good for them to track their emotions so they can do a feelings log, which can be journaling of their feelings, feeling lists. It just helps them better identify triggers and increases their emotional awareness, which will help aid in emotional regulation. Um, and again, like all clients, we just want to approach this very holistically, to emphasize empowerment, connection, help with emotional regulation, and build that overall resilience. So, a little bit more about grounding techniques. These are really helpful when a client is having a disassociation or even a flashback. Kind of helps sensory focus, we can do where we're asking them, like, what are you feeling? Do you feel the feet on your floor? Do you feel the sun on your face? We can use reorienting statements. This is your room. It's Wednesday. It's 2025. And then we can do movement too, because sometimes they'll get a flashback and they'll freeze. So changing positions, walking, can also help break these states. It just increases the client's contact with reality and diminishes those experiences, and it focuses on the present. So final slide in this, always self-awareness, right? You're studying to be a nurse, and the nurse needs to have good self-awareness and self-management in traumatic situations with managing personal emotions, talking about self-awareness. You need to be conscious of your own feelings when working with individuals affected by trauma, especially when the trauma is horrific or involves death, violence, or suffering. Nurses themselves are very empathetic, and with that, they can feel very overwhelmed by the horror and tragedy themselves, and therefore, nurses have developed PTSD from that empathetic, overwhelming, reoccurrent issues. So, we need to make sure that we're non judgmental, we provide unconditional support, but if we're having symptoms or issues ourselves, we always need to make sure that we seek support from our peers or professional counselor. Make sure that we're doing our own self cares, getting good sleep, not using substances, and recognize that emotional toll trauma can have, both on the client as well as yourself. So make sure that you maintain professionalism and take care of yourself.